The next case, my urine is dark. My skin is yellow. My stool is light. I'm feeling so tired. How do you know this isn't Wilson's disease? How do you know it's not Wilson's disease? What would you have with Wilson's disease that you don't see here? Wilson's would give you what? What? I can't hear you. It would give you choreiform movements? Yes, that would be Wilson's disease. Wilson's disease would give you choreiform movements. So it's not Wilson's disease. How do you know that this isn't isoniazid-induced hepatitis? How do you know it's not the INH? Because of the history of taking INH? No, it means it could be the INH. How do you know this is not the INH causing the hepatitis? Well, serology, the short answer is, from what you see in front of you, the short answer is you don't. From what is here, this could be INH. It could be INH. Everything you see here could be INH. Tired, weak, fatigued, dark urine, tenderness, pain. Could be INH-induced hepatitis. Yeah, well, that's not much of a fever, but it still could be. Yeah, doesn't tell much. So the short answer is it could be drug-induced. Wilson's gives you choreiform movements and psychosis. From this history and physical, how can you distinguish between acute hepatitis A, B, C, D, or E? How can you distinguish? Clinically, from history and physical, how can you tell the difference? No history of what? Occupational? What occupation? Eating stool? You can't tell. You can't tell. Statistically speaking, if you had to choose between hepatitis A, C, D, or E, and you just had to choose statistically speaking, what's the most common? A. A is far more common than B. A is far more common than B. Just statistically speaking, it would be hepatitis A. But you can't say that it's not the INH, and all you could do is wait for the blood tests. For instance, my bilirubin is very high, but that doesn't tell you anything. Looking at these blood tests, how do I know that this seems to be viral hepatitis from these blood tests? Because of the transaminases. The ALT seems to be higher than the AST. The ALT goes up more with the viral hepatitis. The AL with the viral. And the drugs make the AS go up. The AS goes up with the drugs, and the AL with the viral. Alcohol, which one is alcohol? It makes up alcohol, because alcohol is a drugs. I know what you're saying. You're like, but alcohol is not a drug. No, it is. It depends on your perspective. So the thing is, from this history and physical, you can't tell anything. From these lab tests, you can tell that with the ALT being higher than the AST, it's far more likely to be viral than it is to be drug-induced hepatitis. The albumin doesn't help you, and the PT doesn't help you. The CBC doesn't help you at all. So there's nothing you can do until you get to the serologic testing. And then you're able to distinguish. Now, what is the treatment for acute hepatitis A? Yes, supportive. What does that mean, supportive? Hepatitis A, acute hepatitis A. What does that mean? Huh? Diet. How does diet help your acute hepatitis? Eating well. Eating what? Eat what, and it makes your hepatitis get better. What are you talking about? What? Eat baklava. Eat baklava. Well, that is unique. You see, the great thing about the way I do classes that interactive like this, you always find a new answer every hour or two. There's something new. for all the broad range of human experience in all these years and all the people in Step 3 courses, no one's ever said, I'd give them baklava QD. Right. I'd treat this person with D5, inshallah. So, the answer is for acute hepatitis A, there is no treatment, and I will finally tell you what supportive therapy is. Ready? This is supportive therapy for acute hepatitis A. Here it goes. Oh, no, honey. I still love you when you're yellow. No, honey. I still find you attractive when you're yellow. I'd wear lots of greens and browns for a while. Blend in. So that's supportive therapy. But there's no, you can eat whatever you want. You could rest or not rest. You can do whatever you want, but it won't make any difference. By the way, there were several oral sex issues that came up on the last break. People came up and said, hey, come here, Dr. Fisher, I want to ask you something. You did not mention oral sex. I would like to talk to you about oral sex. How much do you get with oral sex? And the answer is, it's less than the figures that were up there. It's less than the figures than there were before. So you're thinking, gee, that's very, very little. And the answer is yes. It is very, very little. But it's still there. It's just less. It's very hard to conduct a study like that. The only way to conduct a study like that, you'd have to do it like this. All right, everybody on this half of the room is going to go out and have unlimited, unprotected sex, and everybody in this side of the room is going to wear a condom, and then we're going to see who gets AIDS more, okay? So you can't run a study like that. You can't run a study like that. You can't run a study like that, can you? No. So, but the oral sex is less. Chronic hepatitis. Acute, there is no therapy for any form of acute hepatitis. Chronic hepatitis B is treated with what? Interferon or lamivudine. Interferon or lamivudine. Interferon or lamivudine. Whereas chronic C is interferon and ribavirin. That's good. I say ribavirin, you say ribavirin. Interferon and ribavirin takes a 5 to 10% cure rate for that chronic hepatitis B, and interferon and ribavirin goes from 5 to 10 to 40 to 50. Makes 5 into 50. So therefore, that chronic hepatitis C, interferon and ribavirin is therapy. Acute, nothing. You cannot distinguish any form of acute hepatitis just by history and physical. You need the blood tests, the serologic tests to distinguish. Questions on hepatitis? If the patient still drinks alcohol.
Right, but they get hepatitis C diagnosed. That means the treatment for interferon has to be held until he stops drinking.
You don't have to withhold the interferon for them to stop drinking. Alcohol is not a contraindication to alcohol. Alcohol is not a contraindication to interferon. Alcohol is not a contraindication to interferon. Yeah. The way you can treat hepatitis C, whether it's acute or chronic, is with a liver biopsy. That's it. But don't worry, any acute case you get, never answer hepatitis C. So far as we know, about 80 to 90% of acute hepatitis C is asymptomatic. Hepatitis C is exclusively presents as a chronic disease. So when you see an acute patient, it could be hepatitis C, but don't answer that. When you see an acute patient, it's A or B. E is in Southeast Asia. E is because it's after D. E is because it's enteric. So it's not E, not in the United States. C is asymptomatic during its acute phase, and you just have either hepatitis A or B generally.
Also, for the interferon patient depressed, that means have to be hold interferon until depression going better. Second question is...
I didn't get the first one. What?
If the patient is depressed, do you hold
Oh, if the patient is depressed. Depression is a relative contraindication to interferon.
So have to wait. Okay.
You have to wait until they're not depressed, yeah.
Another question is, I saw somewhere said hepatitis A also can be transmitted by sex.
I see you were getting all quiet and getting nervous because you're saying sex. Okay. Well, I was going to have a seizure. Okay. Can you get hepatitis A sexually? Orally. I say sexually, you say orally. Wow, I'm talking to you. All right. So the thing is, well, we know hepatitis B is sex, blood, sugar, magic. Okay, we know hepatitis B is sex, blood, perinatal, and hepatitis A is transmitted fecal-oral. Or is that oral-fecal? But can you get it sexually? Who thinks you can get hepatitis A sexually? You can, yeah. Interesting to see who. Why am I not surprised? No wonder he looks so relaxed. Okay? The answer is you get hepatitis A, fecal-oral, oral-fecal. That's all I'm going to say. Okay? That's enough. I can't. I might have a seizure. Our question about interferon being relatively contraindicated in depression is an important issue because interferon does make depression worse. Yes? Would you do a liver biopsy? It's not required to have a liver biopsy, no. Hepatitis C is not diagnostic of cirrhosis, okay, but hepatitis C, the antibody tells you got hepatitis C, but it can't distinguish whether you have cirrhosis or whether you're having actual chronic hepatitis or not. The antibody alone is not able to tell you.
Yeah, but how about viral load on hepatitis C?
How about viral load on a hepatitis C? I agree with you. Viral load on hepatitis C can help you to know if the disease is active. I agree. So hepatitis C viral load can help to determine whether there's active viral replication going on. Asymptomatic hepatitis C, yes. If there's a person that has chronic disease, yes, you would treat it even if it's asymptomatic. Most people with hepatitis C who have chronic disease, 80% of them are asymptomatic. Most people are asymptomatic. Follow-up after interferon. Hepatitis C, it would be a viral load. And for hepatitis B, it would be the surface antigen and the E antigen.
Why did the gastroenterologist always ask for a hepatic biopsy?
Why did the gastroenterologist say do a hepatic biopsy? Well, if your only tool is a hammer, every problem looks like it's a nail. Who does the liver biopsies? Who says everybody should have a liver biopsy? The gastroenterologist. Okay? Every urologist I know thinks that you should get a digital rectal exam and a PSA every 20 minutes. That's right. We're not going to get into anything controversial on step 3. That's right. Chronic hepatitis C, interferon, and ribavirin. I'm not going to get into anything more detailed than that. Can you use hepatitis C viral load to follow a response to therapy? Yes. Is a liver biopsy required for every person for treatment? No. If the end point of therapy is to get the hepatitis C viral load to be negative or the hepatitis B E antigen and surface antigen to be negative, then I don't have to necessarily biopsy everybody. Okay. Yeah, last question on this. Do we have to give chronic hepatitis B people vaccinations for what? For hepatitis B? No, you don't have to give it to them. Because if you fix the hepatitis B with the interferon and the lamivudine, they'll convert to surface antibody positive. If you fix them with the interferon and the lamivudine, they'll convert to surface antibody positive, and they're protected. And they don't need the vaccine. Because you make them immune. Next case. I've had a pain in my leg. Okay. Now, I've got diabetes, I've got peripheral vascular disease, I've got a draining sinus tract with purulent material, I've got an ulcer that is red and swollen and tender and purulent sinus tract is draining. What's the best initial first diagnostic step? First of all, what do you think the diagnosis is? I agree with you. I think it's osteo also. And he's had this ulcer for just a week. What do you get first as a test? X-ray or a bone scan? Are you not covering yourself up here?
I just got it.
Yeah, you just got it. Sure, fine. There you go. The best initial diagnostic test is always X-ray. The best initial diagnostic test is always an X-ray. If this person's X-ray is negative and does not show the osteomyelitis, what would you do next? Bone what? Bone scan is exactly the wrong answer I'm looking for. Bone scan has too many false positives. The bone scan cannot adequately tell the difference between the redness, swelling, and tenderness of the soft tissue from infection in the bone underneath it. So the bone scan cannot reliably distinguish between soft tissue infection versus infection in the bone. It can't reliably distinguish. So therefore, you should do an MRI to distinguish between soft tissue infection and bone infection. Now, if the X-ray shows osteomyelitis, can I get that for you? Let me help you with this. I have the perfect thing. Hello? Are you looking for Mitali? Oh, no. She's sleeping right now. Who am I? My name's Butch. No, you can't talk to her. Bye.
Thank you.
Does that help?
Yes.
Keep that relationship fresh. It's all right. Who's your mother? Would anybody else like me to help with your... If the X-ray shows osteomyelitis, what would you do next? Next you do? Did you say treat? Did you say treat? How many times do I have to tell you? You can't answer treatment. Would you like to be specific? What? Nafcillin. All right, let him give Nafcillin. How long you want to give that Nafcillin for? Give him 6 weeks of Nafcillin. Who agrees with that? You agree with him? What's your first name? Rafad. Who agrees with Rafad? 6 weeks of Nafcillin. Oh, you chicken shit. Get a scrotum. What's going on with you? Where are your Harrington rods? All right, we do what Rafad says. He's willing to go it alone. Give 6 weeks of Nafcillin. So you say to the patient, I want you to take 6 weeks of Nafcillin. And the patient says, but how do you know that I have Staph aureus? And you say, I don't. Take the Nafcillin. But if it's Staph aureus, how do you know that it's sensitive to methicillin? And you go, I don't. Take the Nafcillin. But I'm diabetic. I might have gram negatives. I'm diabetic. I might have gram negatives. How do you know I don't have a gram negative? And you go, I don't. Take the Nafcillin and shut up. But how do you know that it's a staph? How do you know it's sensitive? How do you know? You don't know any of that. And he goes, look, Who's the doctor here? You or me? Go home, take the nafcillin intravenously 6 times a day for a month and a half. Look, it's like love, okay? If your leg stays attached to you, it's yours. And if it falls off, it was never yours to begin with. It's like love. If they stay with you, then they are yours. But if they go away, they were never yours to begin with. Or some such crap, stupid ass line like that. I don't know. But you changed your mind. That's a damn good thing to do. You want to do what next? Biopsy or get a handful of the pussy stuff here? I mean, purulent. Culture of what? Culture of the pus. Is the... Getting this? Ow! Ow! Most common wrong answer. Ow, operant therapy. Operant therapy, you know what I mean? Every time somebody goes reaching for something pussy to culture there, it's always going to be wrong. Because you don't want to culture the purulent material coming out of this. Why not? This culture is always wrong. Because? Contamination. It doesn't reliably tell you what's in the bone. By the way, that's the wrong answer I'm looking for. That's the one I'm really looking for. Here's the 2 wrong answers we're looking for. 1, people looking at all the soft tissue swelling here, the redness, the swelling, the tenderness, and ordering bone scans. No. Not when there's all this soft tissue swelling. If there's no ulcer, yes, you can do a bone scan. Bone scans are good if they're negative. If they're positive, they're nonspecific. Point number 2, don't culture draining purulent material ever. It's always wrong. Number 3, you can give empiric therapy, but only after you've taken a culture. A culture of what? Bone biopsy. Bone biopsy. Only after you've taken a bone biopsy. Bone biopsy is next. Then you can take the biopsy and then treat. Let me give you another little clue. Okay? If it's staph, you have to give IV for 6 to 12 weeks. And you know that if it's a gram negative, do you know what you can treat with? Oral. Cipro. And if you put me on intravenous nafcillin 6 times a day for a month or 2 months or 3 months, when you could have had me take pills, I would be really, really, really upset with you. And you would be with me if I did that to you. So you want to know which one it is, because gram-negative osteo can be treated with pills. The gram-positive cannot. Also, without the biopsy, how are you supposed to know which organism it is? You don't know. You don't know. Bone scan is okay if there's not ulceration and all the soft tissue redness and swelling. If there is, then get the MRI. The MRI can tell you, is there infection in the bone or is there infection all in the soft tissue above? If the MRI and the bone scan is positive, what would you do next if the MRI was positive? Biopsy to know what the heck is in that bone. Now, if the MRI is negative, what would you do? No, if the MRI and the bone scan and the X-ray are all negative, it means you don't have osteo. It means you have soft tissue infection. It means you've just got an ulcer. Yes? The Cipro works on Pseudomonas. Yes. Yes, it does. It does work on Pseudomonas. This patient. The X-rays are normal to force you to get all these tests. The SED rate is high. But the SED rate is only to follow the response to therapy. To follow the response to therapy. Not to establish an initial diagnosis. To follow the response to therapy. You follow the ESR. You put them on 6 or 8 weeks of medications. And you repeat the sedimentation rate. And you follow the ESR. Follow the ESR. To see an improvement. The bone scan is positive, but the problem is it's so nonspecific that you have to follow up with an MRI anyway, because you can't tell. The bone scan is only useful if the bone scan is normal. It's sensitive but completely non-specific. Okay? Questions on osteo?
Anything bone scan is really special. No one else, nothing else can really do the job. I was told by radiologists.
No essay answers. There's a film going on. There's 100 people around you. One sentence very loudly.
Okay. Can bone scan do something very special? There's nothing else. But in terms of methodology, can do the same job.
Can bone scan show anything where it's pathognomonic, that it lights up just in a bone scan?
Yes.
No. It's very non-specific.
Is that very sensitive for fracture? Most sensitive that
It is sensitive for a fracture, but that's hardly specific for fracture, though. Bone scan is nuclear medicine. And the other name for nuclear medicine is isotopes. Isotopes. I suppose it could be this, and I suppose it could be that. Before the biopsy? Before the biopsy in a diabetic who probably has gram negatives as well, I give one medication for gram positives and one for gram negatives. Which ones that is, I can't tell you. Next case. This is the last of the major infectious disease cases. We did HIV, endocarditis, meningitis, and this is respiratory infections. I'm having fever and cough and chest pain. Fever and cough, fever and cough, fever and cough. Could this person be having bronchitis? Why not? Pleuritic chest pain? Why else not? It's in the history and physical. Why else not? Shaking chills. And when you see a shaking chill, what does a shaking chill mean? Bacteremia. Bacteremia. When you see a shaking chill, it means bacteremia. And bronchitis is very unlikely to be bacteremic. Give me another reason. Give me another reason. Give me another reason. Hemoptysis. No. You can have hemoptysis with bronchitis. What's the most common cause of hemoptysis in the United States? Bronchitis. Bronchitis. There's another reason here that this can't be bronchitis. There's a shaking chill. The person's quite short of breath. What's a normal... Yeah. Good. That's good. When I get it, you go, yeah. What's a normal respiratory rate? Less than 20, definitely. More like 12. When the nurses falsify the records, they falsify at 20. Okay? Tell them to falsify better. Tell them to lie. Say 12. Here, it's 32. Yeah. But this is the main reason. You don't have focal rales. This person's got consolidation. This guy's got rales in one area. He's got hyperventilation. He's got shaking chills. Too sick to be bronchitis. How do you know that this person is not obsessing? How can we tell that this person is not having a lung abscess? How do you know this person's not obsessing? What? I can't hear you. Fever spikes. Well, we only have one episode here. We can't tell. And shaking chills can mean fever spikes. Huh? Raised aroused, no. What? What about sputum? He's got sputum. Green? How will the color of sputum help? It's like all this wine tasting stuff. Like in the vaginitis. You know what I mean? All this wine tasting. How does all this wine tasting aspects help you? Green sputum, yellow sputum. How does that help you in pneumonias? No, it doesn't help you at all. Also, let me give you the history of the rusty thing. What's the rust in rusty sputum? What is that rust? It's blood. Yeah, ferrous oxide, basically. It's rust. It's Heinz bodies of your sputum. It's and hemoptysis. So rusty sputum can be anything that gives you hemoptysis. It can be anything that gives you hemoptysis. So rusty sputum doesn't help that much because any form of pneumonia, Any form of respiratory infection can give you hemoptysis, chronic bronchitis being the most common. So rusty sputum doesn't help much? No. Color of sputum doesn't help? That's not the thing about the sputum. There is something about the sputum, and the thing about the sputum that helps you in abscess is? It smells bad. That's the thing about abscesses, is the sputum smells bad. There's nothing else where you walk in and go, did a cow in here? Did something die in your mouth? Only with an abscess. Only with an abscess. No, not good enough. Smells bad, and it's got to be chronic. You don't get an abscess overnight. You don't develop abscessions overnight. You have to aspirate, develop a chemical pneumonitis, then a pneumonia. Then you develop an abscess and you cavitate, and that takes several weeks. You don't develop an abscess overnight. Smells bad, and it's very, very, very chronic. Okay? Now, fever, cough, fever, cough, fever, cough. If it smells bad, it's an abscess and chronic. This person is too ill to have bronchitis, and therefore it seems to be a pneumonia. Now, no matter what cause of respiratory infection they give you, whether it's abscess, bronchitis, TB, or pneumonia, the first test is always a chest X-ray. It's always a chest X-ray. Not sputum stain, not sputum culture, because here the X-ray will be normal. Here, and that's the definition of bronchitis. Bronchitis is defined as basically a respiratory infection with no anatomic abnormality seen. It will show an air fluid level in a cavity and an abscess. And it's always a chest X-ray first. You see, now this case is trying to give you a classic case of pneumococcal pneumonia. But the truth is that in most patients, when you take sputum and stain it and culture it and torture it and make it tell you all of its secrets, you still don't get a diagnosis 50% of the time from sputum. So that's why it's not sputum first. Pneumonia. The pneumonia is going to be divided up either into lobar pneumonia, like this, or bilateral interstitial, bilateral patchy, bilateral interstitial disease, which can be this guy has lobar pneumonia. When you see that lobar pneumonia, what becomes the most accurate diagnostic test? When you see that lobar pneumonia, you see lobar pneumonia. What's the most accurate diagnostic test? As what? Culture of what? Sputum. Sputum. Culture of sputum. Okay. When do you wait for results of culture? Never. So you must be taking the sputum and giving the antibiotics while waiting for the results of culture. You take the culture and give antibiotics while waiting for the results of culture. And therefore, you don't have this result. You don't have the result of the culture at the time that you're starting therapy. So the question comes down to, what is the best initial empiric therapy for community-acquired pneumonia? Huh? A macrolide. A macrolide. Erythromycin, azithromycin, clarithromycin. Erythromycin, azithromycin, clarithromycin. A macrolide. But azithroclarithro is better. Azithroclarithro. Am I going to consult a Gramstein? Hello, Mr. Gramstein, how are you? I'm fine. What should I use on you, Mr. Gramstein? A macrolide. The answer is yes. I will consult the Gramstein. It might, but not much. Not much. As a matter of fact, I don't think they'll even go for that too much, because the Infectious Disease Society of America says you should do a Gram-stain and culture, and the pulmonary doctors, the American Thoracic Society, their recommendation says it's not necessary. So therefore, step 3 will not get engaged in discussions like this. You always look at the age of the patient. No. Everybody. Macrolides or what first for initial empiric therapy? Penicillin? No. Cephalosporin? Not first, no. Oral second or third generation cephalosporins are okay, but they'd have to be combined with a macrolide or doxycycline. Not Cipro. Not Cipro. Ofloxacin, no. Levofloxacin, gatifloxacin, moxifloxacin, I love that one, moxifloxacin, levofloxacin, gatifloxacin, moxifloxacin, any one of those, yes, that would be fine, that would be peachy, that would be wonderful, yes, any one of these, this would be fine, any one of those three would be fine. Macrolides or levogatimoxy, macrolides or levogatimoxy. Second and third generation cephalosporins are not as good. It's one of these as the initial empiric therapy for community-acquired pneumonia because you can't often tell who's got what. Now, this case tells you that you got pneumococcus, but you don't know that in most people. And probably the case that you get won't have that on there anyway. And the color of the sputum will not help you. Any cause of cough can give you hemoptysis. For instance, what causes of vomiting give you Mallory Weiss? What causes of vomiting can give you a Mallory Weiss? Anything. Anything. Mallory Weiss. Any of them, right? Any of them. Any of them. Mallory Weiss. The same way, hemoptysis. Any of them. It's like a Mallory Weiss. Retch, vomit. Cough, hemoptysis. What the hell's the difference? I know. Listen, I got inflicted with rusty sputum too. They said, rusty sputum is pneumococcus, and yellow sputum is Haemophilus, and green sputum is this. And this is okay on wine lists for wine tasting qualities, but it really doesn't help. Your issue is this: I have a respiratory infection. Any respiratory infection, if they want you to know it's an abscess before you get the x-ray, they give you weight loss and chronic disease, and it smells bad. A rather healthy person for bronchitis. And the color of sputum and hemoptysis won't help me much. You get an x-ray. Lobar pneumonia, community-acquired pneumonia, the management for both bronchitis as well as empiric therapy for community-acquired pneumonia is just this: macrolides or the new fluoroquinolones which cover pneumococcus. And second and third generation cephalosporins are a second alternative. Not as good because they don't cover Legionella mycoplasma. Okay? Now, the other things that are there that is bilateral and interstitial could be pneumocystis pneumonia, could be pneumocystis pneumonia, could be Legionella pneumonia, could be mycoplasma pneumonia, Legionella pneumonia. It could be viral pneumonia, chlamydia pneumonia. For instance, pneumocystis pneumonia. They'd have to tell you. An HIV positive guy comes in profoundly short of breath with less than 200 T cells and a PO2 of 65. Comes with bilateral interstitial infiltrates, dry cough, shortness of breath, low T cells, hypoxia. What is the next best step in the management of this guy? Oxygen would be better first. And after oxygen? Don't say antibiotics. Would you be more specific than saying antibiotics? You know, macrodantin? Trimethoprim sulfa. So you put them on oxygen and trimethoprim sulfa. He's already on oxygen trimethylbromine sulfa. What would you do now? What's the next best step in the management of this patient now? Steroids. You use steroids if it's severe. You use steroids if the pneumocystis is severe. You use steroids if it's severe. And how do you define severe in patients who have pneumocystis pneumonia? PO2 is what? Under 70. PO2 less than 70 or? AA gradient more than 35. A PO2 less than 70 or an AA gradient greater than 35. Steroids if it's severe. So you put the guy on steroids because it's severe. And 2 days later he develops a severe diffuse maculopapular rash and Stevens-Johnson. What do you use now when he develops a rash that Bactrim? Huh? No. Pentamidine, yes. Now you use pentamidine for active treatment. Aerosol or IV? IV. Aerosol is for prophylaxis. IV is for treatment. Aerosol is for prophylaxis. IV is for treatment. Can you see mycoplasma pneumonia on a gram stain? Doesn't have cell wall. Doesn't have cell wall. Can you see Legionella on a gram stain? Can you see chlamydia on a gram stain? Intracellular, intracellular, intracellular. You can't see mycoplasma on a gram stain. You can't see Legionella. You can't see chlamydia. You can't see viruses. You can't see pneumocystis. Why, there's more atypicals than there are typicals, aren't there? Yes, there are. Yes, there are. There's more atypicals than there are typicals. So the test for mycoplasma is cold agglutinins first, but serology is later and better. Serology is later and better. What will tell you, what will be in the history and physical to tell you to get the mycoplasma serology? Why not get the Legionella serology? What's going to be there to tell you that the person has mycoplasma pneumonia? I can't hear you. Mild constitutional symptoms. That can be anything. Cough. Oh, cough. You're right. Because only this one give cough. Non-productive cough limits it down to this one. History. Everyone has a history. Everyone has a past. X-ray. Oh, interstitial infiltrates. This one. What? Hemolysis. That's warmer. Hemolysis, yeah. That's unique. None of the others cause hemolysis. Why do you get hemolysis? The cold agglutinin. You see, you're saying the things, but you're saying the things that are unique. Not unique. Cough, shortness of breath, bilateral infiltrates. That can be any of them. You're not saying the thing that's unique to the mycoplasma. The thing that's unique to the mycoplasma is, first of all, it'll be the young, healthy person. Yes, walking. You look for anyone who's walking. A person comes in walking. Anybody who's walking. What do you have? Well, you're walking and you have pneumonia. You must have walking pneumonia. But generally, it'll be the young and healthy person, as opposed to Legionella, which is the old cigar-smoking Republican. Diagnostic test for Legionella. That's good. See, that's what I said. It's like straining at school. You're having intellectual tenesmus. The diagnostic test for Legionella. I don't know. We're not getting any answers, but we're having some very good noises this morning. Okay. Okay. I can tell you don't know because you don't make eye contact. Okay? Mitali figures, if I don't look at him, he can't see me. The diagnostic test for Legionella. You were too busy studying Coro. It's true. Serology is wrong. Culture is wrong. Direct fluorescent antibody is wrong. Oh. Don't hurt me. Don't hurt me. I see you in panic room. Okay. What? Silverstein is wrong. A, B, C, D. Hysterosalpingogram will not be an answer. So here's the story. You can't just think of this. You have to know it. People come in and cough, cough, cough. Cough, cough, cough. And you check the urine. Urine. What? What? That's the response I'm looking for. Urine. Cough, 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 cough. Urine. That's the point. Urinary antigen. You can't just figure that out. You have to know it. You can't just reason it out. You can't just arrive at it. A urine antigen. Urine antigen. Urine antigen test. That's the best initial test for Legionella. Now, is it possible that this is too new to be on your test? Is it possible that this is a very current test and that's why you don't know about it because it's just so new? Is it possible? It's possible, but it's not true. Urinary Legionella antigen has a 99% sensitivity and specificity for Legionella pneumophila type 1. And urinary Legionella antigen is the most accurate and specific test for Legionella pneumophila type 1. And the test has been around for nearly 10 years. Ooh. Where have I been? I have been in a coma. I have been in a coma. Huh? The question is, see, you have to now be able to recognize the case, or you're never going to automatically say, oh, look at her. Check her urine. You're going to have to recognize the case. So what's going to be in there that's going to tell you, this person seems to have Legionella pneumonia? Huh? Not responding. That's true. Diarrhea. What else besides diarrhea? GI symptoms, abdominal pain, cramping, diarrhea. LFTs, it's also true. Confusion. CNS manifestations. Confusion, diarrhea. Confusion, diarrhea. Confused older Republicans with diarrhea. GI CNS, GI CNS, GI CNS. Now, nobody here shouted out the usual wrong answer. The usual wrong answer is, look for someone who's been exposed to air conditioning. That's everybody. Okay? Like, so expect somebody who's come in with air conditioner like it's a bong or something. You want to hit off the AC, brother? So exposure to air conditioning won't help you because everybody's exposed to air conditioning. GI, CNS, and air conditioning is a risk factor, but diarrhea, abdominal pain, confusion, disorientation is an individual presentation. Now, chlamydia, I don't have anything nifty for you in terms of associations. You're not going to be able to get asked that too much because it doesn't have a specific association that I can tell you about. I will tell you that as a chlamydia, we know that all chlamydias are diagnosed with... With what? They have high eosinophilia? We will have to agree differently. Like the great philosopher Yogi Berra, you say it gives eosinophilia, and we will have to agree differently. That's a nice way of me saying you're wrong.
Is there Legionella a bad relation between the temperature and the heart rate?
Oh, the dead relationship between temperature and heart rate. That whole thing about pulse temperature dissociation helps you not at all. That is worthless. That is essentially worthless. That's worthless. Where are you from? Venezuela. I was going to go for Brazil, but I got a shot. Okay. So, chlamydia, serology for chlamydia pneumonia. Now, is that chlamydia pneumonia, chlamydia trachomatis, chlamydia psittaci? There's psittaci, there's trachomatis, but what's the type of chlamydia that causes pneumonia called? TWAR? No, there's a type of chlamydia that causes pneumonia, and that's called chlamydia pneumonia. Yeah. Chlamydia pneumonia. And TWAR, TWAR, Taiwan Airborne Respiratory, something like that. First of all, they couldn't call it because they objected to it, calling it Taiwan anything. So the other thing is no one wanted to go around going, what have you got? You've got twar. I got what? Got a twar. Chlamydia pneumonia. Now, even if you don't know anything about chlamydia pneumonia, it's a chlamydia, so it's serology. Its treatment is doxycycline. Lymphogranuloma venereum. What's the diagnostic test for lymphogranuloma venereum? What's the organism? Chlamydia, which one? Trachomatis. Diagnostic test? Serology. Treatment? Doxycycline. Psittacosis. Chlamydia psittaci. Diagnostic test? Serology. Treatment? Doxycycline. Get the point? Chlamydia pneumonia. Chlamydia psittaci. Chlamydia trachomatis. No gram stain, no culture, direct fluorescent antibody or serologic testing. Fluorescent antibody testing or serologic testing, doxycycline. Macrolides are an acceptable alternative for chlamydia. We change this case. We say a guy comes in with fever, cough, and sniffing a sheep. Cough, fever, bilateral interstitial infiltrates. Cough, fever, bilateral interstitial infiltrates. And the guy comes in with cough, fever, and bilateral interstitial infiltrates, sniffing a sheep. I'm sorry, let me be more specific. Sniffing a sheep's placenta, like the Legionella. Anthrax, no, that would be rubbing up against the sheep's wool. Anthrax questions will be on next year's test, not this year's. Too new to be on this year's test. What do you get? Perfect. Who would know this? What do you get from sniffing a sheep? Sniffing a sheep's placenta.
I get sick.
You get sick. Sniffing a sheep placenta? It's the only airborne rickettsia. Coxiella burnetii. Q fever, Coxiella burnetii. But you see that you could not get that unless they gave you the sheep and the animal exposure in the history. Unless they give you the animal exposure in the history, you can't get those answers. They'd have to tell you. Now, I tell you that it's Coxiella is like a rickettsia. So what's the diagnostic test? Serology. And it's like a rickettsia. So what's the treatment? Doxycycline. Even if you know nothing about Coxiella burnetii, I tell you it's like a rickettsia, and you have logged into your brain rickettsia, serology doxy, serology doxy. Rocky Mountain spotted fever, serology doxy. By the way, although I don't think there'd be any other rickettsias on your test, it's basically the same answer for all of them. Prove me wrong. Prove me wrong. Questions on this? Pneumonia. Huh? Oh, the treatment for mycoplasma and Legionella is always macrolides. Macrolides or new fluoro or quinolones. Macrolides or quinolones. Yes. Inpatient and outpatient is people who are more severe. Inpatient is more severe. Now, if you had pneumonia, how would you define severity? Well, lungs are meant to absorb oxygen, so if you're not absorbing oxygen, that means it's more severe. Acidosis, because if you're not absorbing oxygen, you're getting acidotic. Age, somewhat. Out of the top 10 things, age is down here. Age is a risk factor, but hypoxia, acidosis, high fever, high white count, CNS manifestations, these are the individual presentations. Your lungs are not working, I'm hypoxic, acidotic, confused, then you hospitalize them. Go like this so I know you heard me. Yeah, pretty much the same thing. There's not that much of a difference. I do blood cultures before I start anybody on intravenous antibiotics. Blood cultures before you start anybody on intravenous antibiotics. I'm not going to tell you the specifics between the different types of serology for chlamydia, because at your level, to know the difference between indirect fluorescent antibody, direct fluorescent antibody, complement fixation, etc., is too much. Let's take a break. Acidosis, because if you're not absorbing oxygen, you're getting acidotic. Age, somewhat. Out of the top 10 things, age is down here. Age is a risk factor, but hypoxia, acidosis, high fever, high white count, CNS manifestations, these are the individual presentations. Your lungs are not working, I'm hypoxic, acidotic, confused, then you hospitalize them. Go like this so I know you heard me. Yeah, pretty much the same thing. There's not that much of a difference.
What would you do a blood culture? Like in the first case here, would you have done a blood culture?
Do blood cultures before I start anybody on intravenous antibiotics. Blood cultures before you start anybody on intravenous antibiotics. I'm not going to tell you the specifics between the different types of serology for chlamydia, because at your level, to know the difference between indirect fluorescent antibody, direct fluorescent antibody, complement fixation, etc., is too much. Let's take a break. There are a lot of repetitive cases in the infectious disease section. What we covered with most meningitis, we covered all the other forms that you really needed to know about. Here, however, is another form of meningitis. Let's see how much and how quickly you can recognize from the previous case of meningitis that we did. I've got a fever, a headache, and a stiffy. When you have a fever, a headache, and a stiffy, it means you have meningitis. Now, from this history, how do you know the etiology of the meningitis? You have AIDS. It tells you have AIDS. It tells you have HIV under 100 T cells. I have HIV under 100 T cells, and that makes the most likely etiology here. Cryptococcus. Now you'll notice two things. The person's under 100 T cells, so they're on Bactrim. Because they're under 100 T cells. Actually, under 200 they're on Bactrim. They have 2 nucleosides and then a vir. 2 nucleosides and then a vir. What's the most common adverse effect of AZT? Anemia. AZT anemia. DDI? Pancreas and neuropathy, the D drugs, pancreas and neuropathy. Nelfinavir, most common adverse effect? No, Stone's is indinavir. Glucose and lipids for the protease inhibitors. Glucose and lipids for the protease inhibitors. Glucose and lipids. So, the point on this case is that we have HIV and we have meningitis. And how many white cells are you normally allowed in CSF? How many white cells? Up to 10. And how many does this person have? Has a normal white count. The point is that this patient has a normal CSF white count. So a normal CSF white count, yet look at this. High opening pressure, India Inc. positive, cryptococcal antigen positive, cryptoantigen positive, India Inc. positive, high opening pressure. What is the significance of that white cell count in the CSF? There's 4 white cells in that CSF. What's the significance? What's the significance of those 4 white cells in the CSF? It means it's not bacterial. That's true. It means they're going to die of their cryptomeningitis. It's a bad prognostic factor. It means that the prognosis is much worse. When you have HIV, the lower the CSF cell count, the more likely you are to die. The lower the CSF cell count, the sicker you are. The lower the CSF cell count, the more likely you are to be ill and die. The lower the count, the worse the prognosis. That is the significance of CSF white count in cryptococcal meningitis. High opening pressure, positive India Inc., cryptococcal antigen that's positive. And that means worse prognosis. All 3 of those things. High opening pressure, high cryptococcal antigen, positive India Inc., low CSF cell count, and therefore amphotericin, followed by oral fluconazole. For how long, the oral fluconazole? How long? Lifelong, or until the HIV is cured, whichever comes first. Questions on cryptomeningitis? No. Oh, there's 16. Well, yes, well, we already did 16. We're going to go switch to 18 now. I've got itchy red feet that's scaling in red. I'm otherwise well. I'm no chronic medical problems, no medication use, and I deny diabetes. My feet are itchy and red, and I've got in the interdigital web space. There's only 2 things that give interdigital web space problems. Scabies, and tinea. Scabies and tinea. Scabies and tinea. Scabies and tinea are the only 2 things that give you interdigital web space problems, particularly itchiness. You're itchy with scabies because the scabies, the Sarcoptes scabii, is digging under your skin and pooping, and digging and pooping, and digging and pooping. And you're itching because you're having a contact dermatitis to the scabies stool. But the real point on this one is about all superficial fungal infections. All of them. All of them. All superficial fungal infections. Because if we address them as a group, if we address all superficial fungal infections as a group, then it's a lot easier than learning each one by one by one. So tinea pedis is the same as onychomycosis, is the same as tinea capitis, manum, barbi, cruris, corporus. Why is your mouth the same as a vagina? Because the best initial diagnostic test and the same most accurate diagnostic test are the same. Now, whether it's vaginal candidiasis, oral candidiasis, tinea cruris, capitis corporis, body, tinea, and name the part of my body in Latin, why don't you? What's the best initial test for all of them? KOH, potassium hydroxide. Potassium hydroxide. For all of them, it's a potassium hydroxide. KOH for all of them. And fungal culture to distinguish them after you know it's a fungus. So every single one of them, tinea capitis, corporis, manum, unguum, oral candidiasis or vaginal candidiasis, KOH, KOH, KOH. And in terms of treatment, it does deviate. In terms of treatment, it depends on whether there is hair and nails or no nails and hair involved. When there is hair and nails involved, then it's different. When there's no nail and hair involved, then it's anything. You can use anything. If there's no nail and hair involved, you can use any topical. Any topical you want. If there's no hair and nails involved. Ketoconazole? Sure. Miconazole? Sure. Clotrimazole? Why not? Miconazole, econazole, turconazole, nystatin, any topical you want as long as there's no nail and hair involved. If there's nails involved, you can't use topical. It won't penetrate. It won't penetrate. If there's nails involved, the best initial therapy is... Griseofulvin is the wrong answer I'm looking for. Griseofulvin for adults is dead, useless, never, always wrong. Griseofulvin is dead. Amphotericin for a toenail infection. Ooh, that's aggressive. Ow. Amphotericin for a nail infection, for tinea capitis. Ooh, that hurts, Daddy. No. Huh? Keto? Says keto? 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 Keto. How long do you have to treat the nail for? A year. So let's say we put you on the ketoconazole for a year, and you come back in a year. What's your name?
Mario.
Mario. We put Mario on ketoconazole for a year. High dose for his nail. And you say, Mario, how's it going with your toenail after a year? And Mario says...
I had to take it out.
Mario? No. Mario says, how's it going with my toenails? Mario says, my toenails? Well, I don't know. I haven't really been thinking about my toenails. Because since you put me on this wonderful ketoconazole, I have developed the most wonderful, large, C-cupped breastises in the last year. My feet don't itch, but come to think of it, I haven't even... Where are those feet? Oh, feet, where are you? Oh, there you are. Hi. I haven't even seen my feet for a year. Now, but since this ketoconazole, what's the most common adverse effect of long-term ketoconazole? Is what?
Gynecomastia.
Did that word come out of my mouth? No, it didn't. No, it didn't. But it is. C-cup tutors in men. You know, it's a memory exercise, you know. The hard part is that mostly in this is not like this is calculus or theoretical physics. It's not like I'm Stephen Hawking up here or something. Individually, there's nothing individually complex. The problem is how to create memory. Now, once upon a time, the mind of man was very vast and the memory was enormous. A medieval bard at the court of Eleanor of Aquitaine, 800 years ago, could hear all of a 1,000-line poem and remember it all at one hearing. But our minds have become much smaller. So we need things like this. Gee, ketoconazole. What's the most common adverse effect? So you won't be able to forget that even if you try, like a fecalith in your circle of Willis. I'm trying to forget it, but I can't. All right? So things to tag so as to create memory, to make it vivid. Because individually, there's nothing all that complex. Ketoconazole, by the way, is the second most common wrong answer. The most common wrong answer is griseofulvin. Neither of them is correct. When I tell you this drug, you're going to go home tonight, turn on your television, and you'll see there's advertisements every 15 minutes for this drug. The guy sitting there looking at his yellow nails in the bathroom all the time? Lamisil, yeah, Lamisil. Lamisil is the trade name. Terbinafine is the manufacturer's name. Terbinafine is the manufacturer's name. Sporanox is itraconazole. And these two drugs eliminate the need for griseofulvin. Griseofulvin had to be used for a year or 18 months. And after a year or 18 months, you had as much as, a whole 30 or 40% cure. After a year's worth of griseofulvin, you cured 30 or 40%. Here you cure 80% to 90% after 6 weeks, as opposed to 30 or 40% cure after a year. So they're 10 times better. What's the most common adverse effect of terbinafine? Liver. Liver problems. Well, remember, it's any superficial fungal infection, depending on whether there's nails or hair or not. Griseofulvin is okay for tinea capitis in children. So if, like the pediatrician was in here saying, use it for tinea capitis in children, that's acceptable. The brand name? Sporanox. There's a mistake that people make that when I say don't answer griseofulvin, that's in adults, is that then people all get all fussy and they say, well, what about tinea capitis? What about tinea capitis in children? And the answer is, okay, fine, do whatever you want in tinea capitis in children. Griseofulvin. But it's a dead drug for adults. Yes? Okay. Next race. Huh? The same for the hair. Yeah, that's why it says nails or hair. Nails or hair. Nails or hair. Okay. Read the next patient. Next one.
A 28-year-old man. Burning sensation in penis when urinate.
You edited. I should have had him here. Okay, now listen. How do you know that this person does not have cystitis? Because cystitis gives burning, frequency, urgency. How do you know that this is not cystitis? They both give burning, frequency, urgency. Frequency, urgency, burning. Listen, all this case is all a lot of made-up garbage. It doesn't make any difference. But why do you know that this is not frequency, urgency, burning? How do you know this is not cystitis? Discharge. There's vomiting from the head of the penis. That's how you know that this is not cystitis. Cystitis does not give you discharge from the head of Mr. Happy. And that's how you tell. But you see this phrase here about looking for swab, culture, treat, urethral swab, culture, treat, swab, culture, and treat. That is the same for both cervicitis as well as urethritis. Both cervicitis and urethritis is swab for gram stain, culture, and chlamydia enzymes, and then one drug for gonorrhea and one drug for chlamydia, the same as we did before in the other case. Ceftriaxone and azithromycin. Cefixime and doxycycline. Ceftriaxone and doxycycline. One drug for gonorrhea, one drug for chlamydia. One drug for gonorrhea and one drug for chlamydia. The same as we said before. Cervicitis, urethritis. Swab, culture, treat. Both of them. Swab the urethra, swab the cervix. Next case. Questions? Okay, case number 20.
I've got some blisters on my penis.
We are sorry to hear that. I've got some blisters on my penis. What is the significance of him being in Nepal? What's the significance of being in Nepal? What makes you think there's more prostitutes in Nepal, my friend, compared to Los Angeles? Do you know where you live? Believe me, the number of prostitutes per square mile is infinitely greater in Los Angeles than the poor Nepalese, okay? They got enough problems, okay? The answer is nothing. There is no significance of it. There is no significance of it. This history, this physical, guess what they're not going to ask you? The diagnosis. They're not going to ask you the diagnosis. Helen Keller could get this diagnosis. Okay? They're not going to ask you the diagnosis here. This is too obvious. This history, this physical, and all they say is, what would you do next? What you going to do, Doc? Look, that's a lot of step 3. Step 3, a lot of the time, 70 to 80% of the time, they hand you the diagnosis and say, what you going to do, what you going to do. What you going to do? Culture the vesicle. Do you agree or disagree? Disagree. What would you do next? Huh? Counsel him. Counsel him. What does that mean? No glove, no love. Counsel him. Talk to the blisters. What would you do next? Counseling. Culture. Huh? Check him. Check him for hepatitis and HIV. Okay. What would you do next? Zinc smear is a very good answer. What would you do next? No, you'll give him treatment. Acyclovir, famciclovir, valacyclovir, acyclovir, famciclovir, valacyclovir. But you got to get why it's important to get all the answers that were just said. See, some of you don't quite get it. You don't get that figuring out what the most common wrong answers are there is just as good. Zinc prep, culture, counseling for safe sex practices. And what's the best form of safe sex? Sex with the refrigerator door. Okay, that's it. I know. Okay. So, the thing is that Zinc smear would be the best initial diagnostic test. Culture would be the most accurate diagnostic test. He should get counseling. He should be tested for hepatitis B and HIV. But what would you do next? How about giving him some acyclovir, famciclovir, or valacyclovir for his obvious multiple vesicles on the head of Mr. Happy? You see, the reason you can go straight ahead and treat is because the diagnosis is so clear. What else besides, really, what else besides herpes simplex gives you multiple painful penile vesicles? What else? Huh? I see your lips moving, but I don't hear anything out. What? Haemophilus ducreyi is not vesicular. It's an ulcer. What else gives multiple vesicles? Zoster. Shingles. Could this be shingles? What do you mean no? You just said it. Not for this penis? And what's wrong with this penis? That's my new textbook. Get the question number 37, the picture. What's wrong with this penis? Oh, look who shows up just at this time. The reason it's zoster. It can't be zoster. Why not? Because it's dermatomal. You don't get zoster, you don't get shingles breaking out just on the penile dermatome. You get multiple penile vesicles not crossing the midline of the penis? It's not possible. It's interesting you should be showing up at this time. All right. My finest hour. There you go. So that is why you go straight to treatment. Now, they'll never ask you the diagnosis here because the diagnosis is too obvious. If they say, what's the best initial diagnostic test? You will say, Zinc smear. When you're unclear, most accurate is a viral culture. But what to do next is valacyclovir, famciclovir, acyclovir, and they're all the same. By the way, the answers I just said are the same answers for the shingles question. famciclovir, valacyclovir, all of them the same answers. You only do a Zank and a culture when the diagnosis is not clear. I have drips from my ear. I've got discharge from my ear. And this is like the ophthalmologic infection. No stains, no cultures, no smears, empiric treatment. Why do you give the acetic acid? Why are we making basil vinaigrette salad dressing in this person's ear? Oh, I put a little basil, a little lemon juice. Very nice little alcohol. Oh, yes, a little oregano. Why are you putting the basil vinaigrette salad dressing inside this guy's ear? ¿Cómo? ¿Что? Was ist das? You're trying to make his ear acidic again. You're trying to make his ear acidotic. What's the purpose of earwax? Why do we have earwax? Because it wants to keep your canal acid the same way. We said the external auditory canal should be treated the same as the what? As a vagina. Lactobacillus keeps the pH down. Cerumen keeps the pH down. When you go swim, you wash out the acid, the bacteria grow, you treat the topical antibiotics, and you reacidify the ear. What's the point of the hydrocortisone? Which is essentially fertilizer for bacteria. What's the point of the hydrocortisone? You're mumbling and you're going, I'm squeezing his head. It decreases the inflammation, decreases the redness and the swelling and the itching, decreases the redness, swelling, and itching, decreases the redness, the swelling, and the itching. The hydrocortisone. Next case. And final infectious disease case that we're going to cover. You'll notice that it starts to repeat, right? We did a urethritis. It's the same as cervicitis. We did already 2 meningitises. Then there'll be another pneumonia. Then there'll be another meningitis. Then another vaginitis. And it starts to repeat and repeat and repeat. Diarrhea, diarrhea. This history, this physical. Tell me what the single most important word in this whole history and physical is. What's the single most important word in this whole history and physical? Is what? All of them. No. No, not duration of symptoms. Blood. Blood, blood, blood. The most important thing in this whole thing is the fact that some of them have fever and some of them have blood. Fever, blood, fever, blood, fever, blood. That's the most important thing. Fever and blood, fever and blood. Okay? So that's the point here. When you have infectious diarrhea and food poisoning, the most important thing is that you might have blood, but the others have no blood. No blood. For instance, Salmonella might not have blood, but it might have blood. Shigella might have blood, but it might not have blood. Viruses never have blood. If you see blood, it can't be viral. If you see blood, it can't be Staph aureus or Bacillus cereus, my favorite because it's abbreviated as B. cereus. No blood. It can't be Giardia or cryptosporidiosis because they don't give blood. What? Isospora, Giardia, Isospora, Cyclospora. There's only one protozoan that gives blood in the poo. Only one protozoan gives blood. Which protozoan gives blood? Entamoeba histolytica. Amoebic dysentery. Amoebic dysentery is the only one that gives blood. Is amoebic dysentery. Also, it's the wrong complaint. What do people complain of most common? What's the main chief complaint with staph and Bacillus cereus? Huh? Vomiting. This is upper GI. It's mostly nausea and vomiting. It's upper GI symptoms. Mostly upper GI symptoms. What will you look for in a history of giardiasis? Camping. Camping equals death. On step 3, camping equals death. What other group? Campers, hikers, and gay men. That's right. Who said gay men? Camping, campers, gay men, or gay men on a camping trip? A happy camper. How about what? Daycare. Not really. If you see a daycare in a child, say viral. If you see daycare and viral. Okay? Diagnostic test for all protozoans. Diagnostic test for all protozoans is always an ova and parasite exam. Direct examination of the stool and direct examination of the stool. Cryptosporidiosis is in what group? Cryptosporidia is going to be the HIV-associated diarrhea. HIV with less than 50 T cells. Now, it was metronidazole for giardiasis. It is metronidazole for giardiasis. And it's going to be metronidazole for giardiasis. Now, they don't tell you that this person's been having chickens or eggs or any form of poultry. So you can't necessarily say salmonella. They tell you this person's been eating everything and everyone and the recipe for tiramisu. This is what happens when you write cases when you're hungry. They tell you that they only ate shellfish. What is it? Vibrio parahemolyticus. Vibrio parahemolyticus. They tell you, oh, rice. What if these people were eating refried rice? What would be the diagnosis? Not be serious. Be serious does not give blood. Oh, indeed. Well, but that's a lesson by itself. 2 minutes ago I said Bacillus cereus does not give blood. When you see blood, it can't be Bacillus cereus. Now you say, but Chinese food, refried rice, is a risk factor for Bacillus cereus. Blood is the individual presentation. Refried rice is the risk factor. When you're presented with a risk factor and an individual presentation, what's more important, the risk factor or the individual presentation? It wasn't crossing your corpus cavernosum. You must eat more baklava. That's a very big deal, though. No, listen. You see, this is exactly why. You see, when people say, I study and I'm not doing as well as I thought. Why? Because the brain gets mixed up. One of the biggest ones is risk factor versus individual presentation. Medical school. Of course I know that you know about fried rice and Bacillus cereus. It's one of those things that's like axiomatic in medical school. You know what I mean? It's like, hi, congratulations on graduating medical school. Here's your diploma, but one thing first. What food poisoning is associated with refried rice? Bacillus cereus? Very good, you may graduate. And it's kind of like a requirement for graduation. But no matter how much refried rice you have, you still can't get invasive diarrhea that causes blood. Now, E. coli this could be. What would you like to see to know that it's E. coli? Travelers, yes, but something else that's even more important as an association. Huh? Hamburgers, that's warmer. Hamburgers, warmer. Hamburgers are a risk. Last infectious disease case. But this is an individual presentation. Huh? Hemolytic uremic syndrome. 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 Hemolytic uremic. Yep. Now, they don't give you any of this here. They don't tell you about hemolytic uremic. They don't tell you about chickens or eggs or seafood or shellfish. They don't tell you about any of that. They just say generically everything and everybody. When you're going to go statistically, what's the most common cause? Campylobacter. Campylobacter. When you're going to go statistically, it's Campylobacter is the most common cause. Most common cause. Now, there's only one way to tell for sure the difference between these. What's the way to tell for sure the difference between these? Only way to tell for sure is a culture. Now, when you have to treat this, what drug are you going to use to treat these when you have to treat? Ciprofloxacin. When you have to treat these, the treatment is going to be a fluoroquinolone like ciprofloxacin. Most of the time, like these people are going to get fluid and electrolytes. These people are going to give them Gatorade. But when you have to treat, when it's very ill and they're very sick, then you will treat with ciprofloxacin. When they're very ill and they're very sick, you treat with ciprofloxacin. Cryptosporidia has no proven effective therapy. These get better on their own and you don't have to give any therapy. If they don't give you blood in the history, and you don't know which one it is, and they don't give you blood, what are you going to tell the difference? What are you going to use to tell the difference between these two groups of things if they don't give you blood in the history? White blood cells, that's correct, because these all are going to give you white cells, and these are not. This case gives you blood, so you don't have to bother. But maybe your case won't give you blood, and you can only tell them apart with fecal leukocytes. Clear? Questions on this? Food poisoning and infectious diarrhea. The first thing you look for is blood. If you have blood, you eliminate all this. If you don't have blood, you look in the history. Do I have a gay man? Do I have an HIV positive guy? Am I predominantly characterized by vomiting? I do have blood or I have fecal leukocytes. If they don't give you anything, say Campylobacter. What cause? Oh, yes. What? Which one of these is correlated with sexual transmission? You're talking about this? Beef, salads, sugar, melted wine? Which one of these is a sexually transmitted disease? Oh, you were taking that sex with the refrigerator door a little too seriously. Oh, which of these is sexually transmitted? Well, I don't know. We'd have to experiment. I don't know. Which of these? No one's ever asked me that. I would say Giardiasis if I had to pick one. Right. Oh, you're testing me. He's testing me. He's testing me to see if I know. Oh, you're sneaky. You're sneaky. She's testing me. She goes, which of those sexually transmitted? I go, Giardiasis. She goes, correct. Oh. Ow.
Does the word dysentery have any meaning to you, and if so, how would you use it?
Dysentery means invasive diarrhea. When you see the word dysentery, generally means inflammatory invasive diarrhea, and there's invasion of the bowel wall mucosa. So the term dysentery is like vapors or consumption. It's the precise term for this would be invasive, not invasive, to say exactly what dysentery means. Dysentery literally just means bad enteric things. So technically speaking, they're all a form of dysentery, but invasive means white cells, red cells, dysentery. What form of food poisoning causes symptoms the fastest after eating it? Staff is wrong. Thank you very much. Thank you, sir. May I have another one? Come on. What cause symptoms the soonest after eating it? Clostridium botulinum. No. Colder. That's even further away. What causes symptoms within 10 or 15 minutes after eating it, and you have diarrhea and vomit all over the cashier? Giardia. No. Next one, E. coli. No. Again, ow. Who's your daddy? Come on. Viral, no. Yeah, keep naming them all. We'll get to one of those. Keep naming them all. Value like this. Salmonella, no. Shigella, no. Vibrio, no. E. coli, no. With it, Clostridium, no. It causes symptoms 10 or 15 minutes after eating it. You have wheezing, flushing, and diarrhea, and you vomit all over your cashier. Wheezing, flushing, diarrhea. Wheezing, flushing, diarrhea. What? I can't hear you. You're mumbling. Lactose intolerance. Are you trying to tell me something? Lactose intolerance doesn't make you vomit. Lactose intolerance doesn't give you wheezing or flushing. Scombroid. Wheezing, flushing, diarrhea, 10 or 15 minutes after eating it, scombroid. Hey, don't look at me in that hurt tone of voice. Just because you haven't heard of it doesn't mean it's wrong. It can't be. That's not so. It can't be. Why? I never heard of that. It's not related to Coro. No, it's not. I'll have to think about that. It's not related to Coro, though. No. What is the difference between a bottom-dwelling scum sucker? No. What is the difference between a lawyer and scombroid? What's the difference between a lawyer and scombroid? One is a bottom-dwelling scum sucker, and the other is a fish. So the answer is scombroid is a fish that ingests organisms that make histamine. Mahi-mahi, tuna, mackerel, scombroid fish poisoning. Scombroid fish poisoning. Questions on this case? Here is the fundamental issue about the preparation for step 3. Individually, there's not very much individually that's all that difficult. I tell you about infectious diarrhea. I tell you, if they don't give you a characteristic, the most common is Campylobacter. If you can recognize thrombocytopenia and hemolysis, then that's E. coli. I tell you that if there's predominantly nausea and vomiting, it's Bacillus cereus and Staph aureus. Symptoms within 10 or 15 minutes after ingestion, wheezing, flushing, diarrhea, histaminergic is scombroid. Whether you've heard of it or not, it's still the truth. Now, fundamentally, none of those things is individually difficult. Part of this is data. But you know, the information here in these notes, it's the same as what's in the current medical diagnosis and treatment book, as what's in Swanson's Family Practice Review, as in many of the half a dozen or dozen other sources. But what will make us receptive to the information so that we can absorb it? The problem is one of endurance. It's one of endurance. The problem is that there's too much information floating through my brain. Too much information driving me insane. How do I remember? How do I remain permeable? Because here's you. Here is you with phocomelia. And here is all of the information you need to pass the exam. And behind that is the exam. And it seems so big. Oh no, it's too painful. Oh no, it hurts. Because it's like taking a half-gallon enema. Ow. It's a stretch. So here's what you do. What is the point of all that information? What is the ultimate point of that information? Think. You see, the immediate answer that most of you, if you actually honestly say it immediately, free associating, is that it's to pass the exam. Now, if your highest aspiration is the exam, this is going to be very difficult. It's going to feel painful. You'll get it. Look, you'll get it. You'll get it. But the exam is going to seem weighty and painful and difficult. So I'm going to make a suggestion to you. The suggestion is that you have to say, well, it may be that the highest good of that is what you're going to do with the information. What goodness, beauty, meaning, love, service is what the information is for. Now, if you can connect with the meaning, the purpose, the service, what it's for, that it's for something good and beautiful and true and united. That's Aristotle. The good, the one, the true, and the beautiful. Synonymous in Aristotle. The good, the one, the true, and the beautiful. Then what will happen is that the exam and the information will feel much, much smaller. The exam and the information feels smaller if you are allowing this to rain down on you, as the Sufis say, as my friends the Sufis say, where the word for grace, the grace is invisible or unseen rain. Invisible or unseen rain. It's coming down all the time, but you don't feel it. I want you to experiment. So I send the message out. Experiment with this idea. Even if it's not true, is it useful? And if it is true, and you don't experiment with it, then two things happen. The data that you absorb has a much shorter half-life, and it decays. Number two, it feels much worse. And let me give you another thing. Something that you're going to learn through the course of this preparation, at least one thing, maybe many more. Somewhere along the line, you're going to help someone from something that you learned just because of this board test, which now seems like a huge, colossal, literally, pain in the ass, fear, anxiety, deep sense of hitting to my self-worth, particularly if you failed before. If you failed before, and particularly in American society, where your sense of self is so derived from professional success, if this hits your professional success, it hits the sense of personhood, the sense of self-worth. But if you're studying for beyond that, then you become more immune to the pain of the hit to the images to your self-worth. Experiment, and see. Maybe it's true, maybe it's not. But even if it's not true, it ought to be. All of my blessings. Bye.